The next session is guaranteed to make you ponder. The way they gather information, break down and distill relevant information to arrive at a diagnosis will leave you amazed. We welcome Professor Dr. Durayarasan sir. We also welcome Professor Dr. Ravichandran sir, Head of the Department of Hematology, to chair this session. We call upon the next presenter, Dr. Kavya Kirtana from ICH.
Good evening to everyone. 11-year-old female child, firstborn of third-degree consanguous marriage, brought my mother, who hails from Viluppuram, with complaints of progressive pallor and easy fatigability lethargy for past 1 week, with history of regular blood transfusion since 6 months of age. At 6 months of age, mother noticed the child to be pale and was taken to private hospital in Pondicherry, hospitalized, and after evaluation there, parent was informed that the child has a hematological illness requiring periodical transfusions. Later, the child was referred to ICH for further management. Since then, for the past 10 years, the child has history of multiple blood transfusion, once in a month for past 10 years, getting transfused for either 1 or 2 days during each visit, amounting to around 15 to 18 transfusions per year. After about 3 years of regular transfusion, the parent was counseled to start on some oral medication to prevent transfusion-related complications. At around 3 to 4 weeks after each transfusion, child develops history of progressive pallor and history of lethargy, which improves only with subsequent blood transfusions. History of gradually progressive abdominal distension, insidious in onset, involving predominantly the upper abdomen, not associated with abdominal pain, puffiness, facial puffiness, leg swelling, or diminished urine output. Now, the mother noticed the child to be stunted in growth. No history of breathlessness, palpitation, generalized swelling, or jaundice. No history of fractures or joint pain. No history of skin hyperpigmentation or dry skin. No history of polyuria, polyphagia, or polydipsia noted. Past history, no history of significant illness requiring admissions other than blood transfusion. No other chronic comorbid illness. No history of neonatal jaundice requiring transfusion or intensive phototherapy in the child. No history of previous abdominal surgery. Developmental history is age appropriate. Immunization, immunized up to age according to National Immunization Schedule. No special vaccines have been given. Family history, siblings and parents have been screened and informed that they too have a hematological disorder not requiring regular transfusion. On general examination.
Just before that. See, generally when you present a short case, we tell you the system and we need only the history which is relevant to your case as such. So you will not get a big case presentation like as you get in a long case. Okay, so this is to be discussed only as a short case, and for a short case you are given a very short time, so you should not be wasting your time trying to take all the history. Only the relevant history need to be taken. So with that history, what is your analysis and what is your conclusion before you go into the general examination?
The first symptom started around 6 months of age in the child, sir. And mother initially noticed progressive pallor, for which she admitted. And since then, the child is on regular transfusions for every 3 to 4 weeks, sir.
So with that, what were the conditions which ran to your mind?
Hemolytic anemia should be my first possibility. Most commonly requiring regular repeated transfusions, most probably thalassemia major.
Okay.
And in neonatal and early infancy, the presentation is there, so possibility of hereditary spherocytosis will also be there, sir.
Okay. So how will you differentiate in the history between hereditary spherocytosis and TAL or hemoglobinopathies?
In hereditary spherocytosis, presenting in neonatal form will be severe with severe unconjugated hyperbilirubinemia requiring exchange transfusion. But thalassemia major will usually present around 6 months of age, 5 to 6 months of age, because of transition from fetal hemoglobin to adult hemoglobin. Gamma chains will be there till 6 months of age, sir. Only when beta chains begin to appear by 5 to 6 months, the child will develop progressive pallor.
Hemoglobinopathies, most probably, and then hereditary spherocytosis. Did anything else come into your mind?
Requiring regular transfusion and involving with progressive pallor, I thought of congenital sideroblastic anemia or congenital dyserythropoietic anemia as a rare possibility. But,
And just before that, unstable hemoglobinopathies.
yes, sir.
Okay.
Yes, sir.
So you have very few conditions which will present requiring these kind of transfusions. Okay. Hereditary spherocytosis generally does not require these many transfusions, so that goes out of your picture as such. So you have thalassemias, unstable hemoglobinopathies, and then your congenital
Dyserythropoietic anemia.
dyserythropoietic CDA and
Congenital sideroblastic anemia.
sideroblastic anemia. Okay, fine. So you had these 4 in your mind. So with these 4 in your mind, what did you examine for? General examination. And also the fact that she has been on transfusion for last 10 years.
10 years. General examination and head to foot examination. Child appears stunted and appears dark, comfortable at rest, not dyspneic. Face is characterized by frontal bossing, prominence of malar eminence with that protrusion of maxillary teeth, depressed nasal bridge, characteristic chipmunk faces was present, neck normal, severe pallor present, no chest deformities, abdominal distension present which is more in the upper abdomen, limbs are normal, not icteric, no cyanosis, no clubbing, no lymphadenopathy, no markers of bleeding, mild pigmentation of palms present, no bony deformities, spine was normal.
Okay. So you have, can we go back to the previous slide? Is there something which is contradictory to what you present? Findings which are contradictory? Severe pallor and comfortable at rest, not dyspneic. Can they coexist? Severe pallor and child comfortable at rest are not dyspneic. Do they coexist? Is that okay? Want the mic to be passed?
Anemia of chronic disease is a possibility.
Possibility is that they may not be,
Dyspneic.
they may be comfortable at rest. Agreed? Not dyspneic?
They usually compensate pretty well, sir.
Yeah. How do they
On
compensate?
account of chronic hypoxia,
How do they compensate?
they have cardiac remodeling and they are relatively less dyspneic, sir.
They are dyspneic.
They are,
So that is the contradictory statement, isn't it? Probably you have taken the history prior to transfusion and after transfusion. So prior to transfusion you saw her with severe pallor, and then post transfusion you must have seen her and she is not dyspneic. They usually have a chronic dyspnea. Okay? There will be some amount of increased respiratory rate and some amount of effort intolerance. So this is the child is on the way, I heard. Okay. Comment on the face. Frontal bossing, yes. Malar prominence. Malar prominence, anything else that is striking?
Anterior maxilla
Yeah.
protrusion.
Actually there is a prognathism and this child would have its mouth always open. Okay? You saw that the other kid who was sitting there. So because she had taken a photograph, she had consciously tried to close the mouth and pose for the picture. Okay? Anything else? Can you comment about the skin color? Is it yellowish? I don't see any yellowish discoloration. There is something to it. Ever heard of the term sallow complexion? This is something similar to that. You have jaundice with anemia and with iron overload. So you get a different color of a skin actually. Okay? Right. Let the case come, then you will see it. Go ahead.
Anthropometry, the child's weight is 23 kg at 3rd percentile and height is 118 centimeter, less than 3rd centile, BMI 16.2, vitals, temperature 98.4 degree Fahrenheit.
Comment about the anthropometry.
Weight, both weight and height or lesser.
Okay.
A child is first stunted.
Okay.
Child is having chronic malnutrition. Sir.
Would you like to rephrase your answer a bit? Ever heard of the term growth retardation? So this is the classical growth retarded child, isn't it? So what does it indicate? Why does it happen?
Same chronic hypoxia.
From the audience. Chronic anemia can produce? How does it produce it? So chronic hypoxia, what does it produce? Chronic hypoxia produces what? So why should the growth be retarded if there is a chronic hypoxia? Tissue will not grow. Produces hypercatabolic state. Okay, so what you are seeing here is a hypercatabolic state. So whenever there is a chronic hypoxia, it induces hypermetabolism. Okay, so you may give a lot to the child, but still it will not grow. It produces a hypercatabolic state. Her basal metabolic rate would be very high. Go ahead.
Heart rate is 90 per minute. Pulses normal volume, regular rhythm, no specific character, felt in all peripheral vessels, no radioradial or radiofemoral delay, no vessel wall thickening, respiratory rate is 22 per minute, thoracic type of respiration, blood pressure is 160, measured in right arm in sitting posture, capillary refill time is less than 3 seconds, systemic examination, abdominal examination, inspection, abdomen distended, more in the upper half, flanks free, umbilicus midline inverted, all quadrants moves equally with respiration, skin over the abdomen is normal, no dilated veins, no scars, no sinuses, hernial orifice is free, external genitalia is normal. Palpation, superficial palpation, warm, not tender, mass palpable in the right hypochondrium and left hypochondrium. On deep palpation, liver is palpable 5 cm from the right costal margin, firm, non-tender, margins well defined, moves with respiration, no nodules felt. Liver span is 11 cm, spleen palpable 7 cm along the long axis, firm, non-tender, moves with respiration, splenic not felt in the anterior border. On percussion, no free fluid, auscultation, bubble sounds heard normally, no audible bruit. Cardiovascular system examination, first and second heart sounds heard. P2 normal, a systolic murmur of grade 2/6 intensity is heard in the pulmonary area. Respiratory system, normal vesicular breath sounds heard, air entry equal on both sides. Central nervous system examination, no focal neurological deficits, bilateral plantar flexor. Positive findings, anemia requiring regular blood transfusion, short stature, hemolytic phases, hepatomegaly and massive splenomegaly. Provisional diagnosis, a case of chronic hemolytic anemia, probably thalassemia major with no clinical signs of transfusion related complications.
So this is a typical case, possibly what we say, the patient has read the book and it has just followed. So what is your comment or your opinion about the management of this case? Do you feel it was okay so far, but it has been continuously treated in ICH?
Yes, sir.
Leah, you feel that the child is doing good?
Sir, my mother says that every 3 or 4 weeks the child is getting progressive increased fatigability, lethargy. So
Okay,
increased
increased
transfusion need is there.
Major. Okay.
Then hepatitis vaccine should be given prior to transfusions.
Okay, fine. Hepatitis vaccination could have been given, but the child doesn't seem to be suffering from any transfusion related infections even. Okay, but precautionary should have been given. Would the child have received hepatitis B vaccination in the national immunization schedule?
Yes, sir. In national immunization
When did
schedule.
they introduce hepatitis B in national immunization schedule?
2000.
When was hepatitis B introduced in national immunization schedule? When was your Pentavac started in national immunization schedule? Can we presume this child would have already received hepatitis B vaccination?
First கேள்விக்கு ஆன்சர் பண்ணனும்னா ஆட்டோமேட்டிக்கா செகண்ட் கேள்வி வந்துரும். When was hepatitis B introduced in the national immunization schedule?
(2010 to 2011) is the time when it was introduced. Okay, so this child 2010 to 11. So this child now 11 years. There is a query whether this child would have received hepatitis B vaccination. Yes, okay, we could have thought about hepatitis B vaccination. What else can you comment about this child's management so far for the past 10 years in our institute?
10 வயசு ஆகுதா குழந்தைக்கு?
Anybody can say. You feel that the child has been managed well?
No.
There is definitely a growth retardation.
If somebody says no, they should say why.
There is also an hemolytic phasis. The growth is retarded. The child weight is also compromised. Okay. Anything else? We don't know whether an iron overload has been monitored in the child. Okay. A huge spleen of 7 centimeters shouldn't have been there provided the child had been taken care of properly. Clear? So what we can infer is possibly there is a treatment, the child has not gone in for a major complications, but still it could have been followed up better. So what could have been done better? So what should have been our targets? Just for discussion sake, you can enumerate. What is the ideal management? What should be the targets?
If you want this child to grow well, supposing I give you another child and you want that child to grow well, so, or not have a spleen of this size, what would you do?
Sir, should do regular transfusion, sir. There are 3 kinds of regimen: moderate transfusion regimen, hyper and super regimen, sir. Initially, palliative regimen was followed. In hemoglobin was maintained around 8.5. It doesn't cause significant illness, but growth retardation and fatigability was there, sir. Now we are following moderate to hyper regimen. In moderate regimen, the pre-transfusion hemoglobin is maintained around 9, and the mean hemoglobin of 11 is maintained. In hypertransfusion, a pre-hemoglobin level of 10 and post-hemoglobin level of 12 is maintained, and in supertransfusion, a pre-hemoglobin level of 12 and the mean hemoglobin level of 14 is maintained. So ideally, the child should be maintained in moderate or hypertransfusion to prevent this hemolytic phasis or massive splenomegaly from occurring, sir.
Why not super?
Super transfusion is generally not followed because it increases the iron overload chance, sir. Hemosidrosis is more with super transfusion, so they are not following the super transfusion regimen.
Same thing happens with moderate and your super hypertransfusion also. The load is the same basically, isn't it?
But hypoxia is lesser. With every transfusion, you are reducing the hypoxia, and so the growth will be better with this transfusion.
Basically, super transfusion was originally thought of as the answer, and then they found that for the same amount of volume that was transfused with respect to the hypertransfusions, they found that children were actually doing better without much of iron overload, provided you gave chelating agent. Okay, so super transfusions did not confer any additional benefit. On the other hand, they actually increase the iron overload, and so that is the reason why they have given up super transfusion. Now the aim is that you should have it at a level somewhere between 10 to 12. So we follow the moderate transfusion. Considering that every blood transfusion is associated with one, iron overload, second, transfusion related complications.
Okay, now the standard of care is moderate transfusion, where your pre-transfusion hemoglobin has to be 9 to 10. What are all the advantages of your moderate transfusion regimen, or maintaining your pre-transfusion hemoglobin of 9 to 10?
With blood transfusion,
do we transfuse for other kids with 9 to 10 for anemia of other causes? We don't.
We don't.
No.
To prevent chronic hypoxia, sir,
Okay.
and to prevent the hypercatabolic state, thereby ensuring growth of the child, and also to decrease erythropoietin production, because increased erythropoietin also causes increased absorption of iron from the GI tract.
Okay.
Fourth
Fourth point. Okay. The main target, the main difference between treating other anemia is that we treat only the anemia. We don't want the child to be suffering because of anemia, hypoxia and complications. Here in the moderate regimen or in Thal major, what is our target is to suppress the extramedullary hematopoiesis. So we need to maintain a hemoglobin of around 10, or as she said rightly, the average of around 10 to 11 to suppress the extramedullary hematopoiesis. And this child clearly shows that there is ongoing extramedullary hematopoiesis. That is why the hemolytic facies is there. So we should have maintained an better hemoglobin concentration. Okay, fine. Can this child be investigated now and did anything better, or can we change the regimen of treatment now? Instead of moderate, can we have any other regimens?
Hypertransfusion regimens can also be followed in this child,
Okay.
sir.
So once we have a kid with an extramedullary hematopoiesis going on, we can try hypertransfusion regimen. Once the extramedullary hematopoiesis gets controlled, then we can scale it down to your moderate transfusion regimen. That can be done in this kid. Okay. Apart from this growth failure because of your inadequate transfusion regimens, will there be any other reason of growth failure in this child? And this child is a female child, 11 years complete, I suppose, no?
Yes, sir.
Ideally, we should have had a Tanner staging also.
Tanner stage 2, sir.
2. Okay, fine. So Tanner stage 2.
Yes,
So that is age appropriate. So we don't have to worry. Should we think about anything else for the growth failure?
For short stature.
Short stature, growth retarded.
Short stature can also be due to iron accumulation causing hypoparathyroidism. Calcium and vitamin D levels will be altered, causing growth failure, and iron deposition,
Okay, so iron overload causing endocrinal problem, could be pituitary, could be growth hormone deficiency, could be there. And de novo, your thalassemias can cause retarded bone growth, and there will be early epiphyseal growth, and long bone shortening is known complication of your thalassemia. Okay, fine.
Supposing this child comes to you at 18 years of age, which transfusion regime would you choose? Or what would be the level at which you would like to maintain the hemoglobin?
at 9.5 to 10.5.
Okay, why? I agree with you, but why? I would go with the lower range than the higher range. Somewhere between 8.5 to 9.5 is okay with me. 8 itself is okay. Can you tell me why?
After 18 years of age, the growth plates will be closed, sir. So,
Just take it forward a bit, you get the answer.
extramedullary hematopoiesis.
The aim of transfusion was initial phase. What was the aim of the transfusion in the initial phase? Why did you think about a transfusion in the early phase?
To prevent chronic hypoxia, thereby which causes decreased growth, which suppresses the growth in this.
Isn't it? That this child should grow normally, and so you wanted to give transfusions at regular intervals, maintaining the hemoglobin somewhere between 10 to 11. So that has been removed. Now what is your aim post adolescent transfusion or during the once the growth plates are fused? What would be the objective of transfusion? Is it still the same?
No, sir.
So what has changed?
No need to maintain growth, sir. Sufficient to maintain the normal metabolic state is enough.
Yeah. So the aim of the transfusion now is to prevent iron overload. Is to prevent the complications of
Iron overload.
So the paradigm shift occurs, and so the hemoglobin is usually maintained between 7 to 8. Okay, so it's okay if you can maintain at 8.5, but 7 to 8 is good enough. Okay.
What is the ideal monitoring schedule for a baby with thalassemia, and what are all the things to be monitored?
For a child with thalassemia, every monthly complete blood count, liver function test and renal function test should be done, and every 3 monthly growth monitoring should be done, and every 6 monthly serum ferritin level should be monitored, and every year viral markers, hepatitis B, hepatitis C and HIV viral markers should be done. And if the child crosses 10 years of age, then annually sexual maturation rating, calcium, phosphorus, vitamin D levels, echo, ECG, T2 MRI, liver MRI should be done, sir.
Okay. Default we need to do cardiac iron load and liver iron load after 10 years. Should we do a cardiac iron load or a liver iron load checkup after 10 years? Even if the child is going to be managed properly with a good transfusion regimen? Yes or no?
The question is,
yes.
Do you have to do it only at the end of 10 years? Number one. Number two, if you have done it before, do you still want to do it at 10 years? There are two questions to it. There are two parts to it. When will you first do it? The second one is, would you like to do it default after 10 years?
Okay. So default at 10 years, if it is abnormal, if it is normal, every 2 to 3 years we have to repeat, sir.
Okay. Default you need to do it at 10 years because how will you maintain the child with a very good transfusion regimen and a very good oral iron chelators? The iron overload problems will not be addressed completely. Okay. So any child after 10 years, it has to undergo an evaluation. That is a must. But when should we think about doing it yearly? Whenever the serum ferritin is going to be more than
1000 nanogram per ml.
Nanogram per deciliter or micrograms per liter. So whenever, so you keep monitoring your serum ferritin. Whenever your serum ferritin is going to be more than 1000 for 6 months together, that is 2 values, then you start investigating for your iron overload in the liver and the cardiac. Depending upon the iron load, you will have to titrate your oral iron or your parenteral iron chelators. Okay, fine.
So we were talking at slightly higher level. So let us bring it back to the basics as such. Okay. So we talked about transfusions. Agreed. So along with transfusion, this child had some drug which was given at 3 years of age. Was that the correct? So when would you think of using an oral iron chelator, or are there any other iron chelators available?
Iron chelators are usually started if the serum, if more than 10 transfusions, if serum ferritin level is more than 1000 nanogram per deciliter.
Is it always after 10, or is it 10 and?
After 10 you should do a serum ferritin level, and if it is more than 1000 you have to start on oral iron chelators.
Okay. So what would be the dose? What would be the drug to be chosen?
There are 3 chelators currently available. One is deferoxamine. Deferoxamine is given either IV or subcutaneous. The half-life is very short, 20 to 30 minutes. So it needs to be given for a period of 12 to 14 hours a day for 5 to 7 days a week. So compliance is a main problem with the patient.
What happens if you just give it after immediately? What happens generally is that somebody comes, gets the blood, and then somebody just pushes the desferoxamine IM, and then they just send them off. So if that were to be followed, what is it that you expect? What happens actually there?
sudden injection, sir.
No, you just give the injection, tell them that you have this injection because they have to go, and so they go off. Nobody follows the 14 hours regime. Sometimes they give it IV slowly and then give it over a period of say about 6 hours and then say go back. So if that were what you follow, what would happen? Why are we not following that regime? After all, for a Thal, time is precious. The parents have to go back home. The child has to go back to the school or whatever he is. And then you tell him that he has to be here for 5 to 7 days, 14 hours of injectable. So,
Desferal pump is used, sir.
no, but why are we not following that previous regime?
Desferoxamine doesn't remove from the from intracellular iron. It won't remove, sir, from extracellular sources.
That is the disadvantage of desferoxamine. That is a disadvantage. But why are we not using that?
What is
of
the
6
half-life
hours?
of desferoxamine?
20 to 30 minutes, sir.
So what happens because of that?
So if you give it faster, there won't be a lasting effect,
So what
and the purpose of giving it will be negated.
So what would happen is it will remove off all those iron which is available in the immediate vicinity within that 20 minutes period. And after that, there are long periods of iron overload. Okay, and that is much more harmful. So that is why you need to give desferoxamine slow subcutaneous. So you use a pump. Okay, the disadvantages.
It doesn't remove cardiac iron. I mean, intracellular iron, it doesn't remove, sir.
Number one, that is the drug effect. Slow subcutaneous infusion. What are the problems?
Injection site reactions will occur, sir.
Good. Next.
Then side effect of desferoxamine is ocular and auditory toxicity and bone changes. Metafacial dysplasias will occur, sir.
Okay. Then between these three, which is the best drug? You have talked about one drug. Tell me about the other two drugs.
The other two drugs are oral drugs, deferasirox and deferiprone. Deferasirox is it has a long half-life of 12 to 14 hours. So deferasirox.
Okay.
So it is given once a day dose, sir. It should not be mixed with the plastic thing. It should be mixed in a. It should not be mixed with metal-like.
Correct. Those are the instructions that you give to the parent how to give the drug. Okay. Then. So how much of iron does it remove?
Deferasirox, it mainly excretes. It conjugates and mainly excretes in the feces, sir. It 1 gram will remove 93 milligram of iron. And side effects, it includes transient renal changes, increased serum creatine, and GI symptoms, nausea, vomiting, GI symptoms. And deferiprone, it has a half-life of 3 to 4 hours. So it is given 3 times a day at a dose of 75 to 100 milligram per kilogram per day. The side effects include arthropathy and agranulocytosis and neutropenia. So blood counts should be done 2 to 4 weekly interval if the child is on deferiprone.
So tell me of these three, which are the best?
Ideally, combination therapy is best, sir.
Which combination would you like?
Desferoxamine plus deferiprone.
Why?
Due to shuttle hypothesis, deferiprone, it removes from cardiac iron and from intracellular iron, and deferasirox, it removes the extracellular iron. So amount of iron excretion is good, so the combination therapy is preferred.
Yeah. Actually, weight for weight, desferoxamine is a better drug. The only problem with desferoxamine is that it has got a very short life. Every milligram of desferoxamine will remove 1 equivalent. It removes that kind of a thing. With deferasirox, it removes
93.
2 milliequivalents of 2 milligrams of this will remove only 1 milligram of iron. That is the ratio. Okay. Deferiprone has got a slightly better ratio than that of deferasirox. But again, the problem is that individually it's not a nice drug to give, it is a toxic drug. Okay, so the best way is combine deferoxamine and
Deferiprone.
Okay, so that would help in removing the cardiac and liver ions. Okay, how will you
Do you give a combination therapy for all children with thalassemia?
Mostly it is given for patients with cardiac overload, sir.
Okay. So generally for choosing an ion chelator, you don't go for a combination regimen. Combination regimen is chosen only when you anticipate or diagnose an cardiac ion overload or an liver ion overload. Okay, generally no. And desferoxamine is best drug out of the three because it has got a very good safety profile. The toxicity is very less. So that is one of the main reason why that is a better drug, but because of the long time infusions and all, we need to find a oral drug. And out of oral drug, desferoxazox is the best, but we don't get it here more often. Okay.
So how do you identify an iron overload? One is by serum ferritin. Okay, is that a good method? What is the disadvantage of using
It is a
serum
cheap,
ferritin to
easily
identify
available
iron overload?
method.
Huh?
It's a cheap, easily available, so we are using
That
it.
is the
sir.
advantage. What is the disadvantage?
Ca-
Acute phase reactant, we need to rule out infections and inflammation whenever we are doing a serum ferritin levels. Yes. So false positively you may be having high values. That's why the recommendation is you need to wait for a serial or at least 2 values of an serum ferritin to be higher before embarking on a
Therapy.
therapy.
Okay. Oral.
Okay.
No.
Fine.
But otherwise, is it a good marker?
no, sir.
It's a cheap and it's a cheap and screening device. Agreed. Okay. But why is it not that good a marker? It's not a bad marker, but why is it not that it is that good a marker? It does not reflect
Cardiac iron overload, sir.
cardiac iron overload. Okay. So how do you diagnose a liver iron overload first? Then we go to the cardiac.
R2.
Which is the best modality to identify a liver iron overload? Liver biopsy. Who's the liver biopsy? I want to know why you think liver biopsy is the best way. Agreed. Liver biopsy is one of the ways, but why do you think liver biopsy is the best way? Gold standard. Okay, liver biopsy is the gold standard. Then, any other answers? Any other answers? Directly measures the iron load. Okay. Okay. That is exactly the reason why liver biopsy is not that good, that is no more considered a gold standard. Okay. So when you do a liver biopsy, you are not actually measuring the amount of iron which gets deposited in the body, in the whole system. It is not an indicator. Okay, number one. Number two, liver biopsy does not correlate with cardiac iron load. So doing a liver biopsy is useless basically. So don't even try it. Don't even try it. A better marker would be
MRI, liver MRI,
MRI. Disadvantage?
non-invasive technique.
Disadvantage.
It doesn't reflect cardiac iron overload, sir.
Same point. The same problem is that there is no point in measuring a liver iron values because it has no meaning if you have to interpret it with respect to cardiac. Okay. So when will you suspect a cardiac iron overload or cardiac deposit?
In presence of cardiac failure, symptoms wise,
Could be because of the anemia and failure.
arrhythmias, sir.
Arrhythmias. If you have a child with arrhythmia presenting to you with arrhythmia and failure, always suspect that it is cardiac toxicity, cardiac iron overload, and that is the best clue. And then a child who does not respond After transfusion, generally your features of acute left ventricular failure will start disappearing. Okay, breathlessness will decrease, child's well-being will increase, the tachycardia and all will come down. But in a child with cardiac ion overload, you will find that the child does not respond as well following a transfusion. Okay, so in such situations, you have to do a cardiac ion status. So how would you measure it?
Cardiac T2 cardiac MRI, sir.
So what would you see?
Iron accumulation, hemosiderosis in ventricular chambers. Generally, it won't deposit in atria and the conducting chamber. It has more predilection for the ventricular chamber. So, I know it.
I think it's a bit too much for your thing, so we will skip that.
Okay. What precautions you will take about the transfusion?
Ideally, before starting transfusion, the donor blood should be completely screened for ABO, RH, and minor blood group compatibilities should also be done.
When will you do that? Ideally before transfusion? Every transfusion?
Before every transfusion, sir.
Every transfusion.
Before every transfusion, sir.
Yes, the ideal way is to have an extended matching, or it is called as your otherwise molecular matching. Okay, what are all the advantages? A low immunity, antibodies would not develop. So that is the ideal thing. What precaution, what is the definitive treatment for your thal major?
A stem cell, hematopoietic stem cell transplantation.
Okay. If I am going to plan for an stem cell bone marrow transplantation for a kid, what precaution I should be taking in the
should use leukocyte filters, sir. HLA matched. Before
HLA matched.
Before transfusion.
Irradiated blood has to be used if I am going to plan for an bone marrow transplant, because there will be graft versus host reaction. So if you are diagnosing an thal major early and you are in the course of finding out an HLA matched donor and planning for an bone marrow, you should ideally prefer an irradiated blood. For regular transfusions, you need to do an extended matching and then leukofiltration. Leukofiltration means when all your leukofiltration is done?
There are two types of leukofilters.
Yes.
One is pre-transfusion at the after collection they will do, and another is before at bedside before transfusion.
Okay. So bedside before transfusion, it is called as your leukofiltration. They have a separate filter in your blood set which is called as your leukofiltration, but that doesn't remove your leukocyte released chemokines or leukotrienes. So still the chances that there will be reactions are high. So ideally the leukoreduction has to be done before storage. So you need to be very specific when you are going to transfuse an thal cases. Because of the repeated transfusion, it has to be extensively matched and it has to be leukoreduced. If you are planning for bone marrow, it has to be an irradiated blood. Okay.
Do you have any other questions?
Okay, Pa. What is there in your next slides?
Investigations. Initial investigation, it include complete blood counts, reticulocyte count, peripheral blood smear, serum bilirubin, serum iron ferritin, total iron binding capacity, HB electrophoresis or HPLC. Nestrov test is for screening.
Can we just go to the previous slide? Can you just explain why you want to look at total iron binding capacity and transferrin saturation?
Initial investigation, sir, not regularly.
No, why?
In thalassemia, that iron binding capacity will be reduced and transferrin saturation will be increased, sir. Thalassemia major.
Okay. And HPLC?
She says it is at the diagnosis of thal major.
Yeah, that's what. HPLC. Hemoglobin electrophoresis and HPLC, what will it give you?
In HPLC, if the patient is thalassemia major, the HbF level will be increased, sir. And HbA2, it will be more than 3.5, there will be mild increase, and HbF will be up to 80% increase, and HbA level will be reduced or absent. In thalassemia trait, HbA2 level will be more than 3.5, sir.
Okay. See, basically it will help you. Whenever we talk about hemoglobinopathies, unfortunately we only keep beta thal in our mind. So the other condition also need to be kept in mind, and that would be alpha thalassemias, and we don't call them as alpha thalassemia and beta thalassemia, we know them better as HbH disease. Okay, so all of them put together are called as hemoglobinopathies. So your HPLC and hemoglobin electrophoresis would help in identifying those types. In alpha thalassemia, the A2 levels will be low or normal. Okay, while in beta thalassemias, the A2 levels will be more than 3.5 as such. Okay, so that gives the clue. The HbF will actually mastermind about your transfusions. They are not so easy as we discussed it here. So presence of HbF, if it is significantly good enough, then the child may not have manifestations and it may not require that many transfusions as such. Okay, so I think our time is up. If Srinivasan permits, I'll take just another 5 minutes, 2 minutes. Okay. Finally, there are 3 questions which you have to, questions which would come and you will probably have to know about it. One is other drugs used, the role of hydroxyurea. Number 2, genetic therapy. Number 3, prenatal diagnosis. Okay. So if we can quickly finish each one in 1 minute, then we wind up.
Hydroxyurea is used to increase the HbF. It is mainly an anti-metabolite, DNA anti-metabolite, so it increases the HbF levels, thereby decreasing requirement of iron transfusion in thalassemia intermedia and thalassemia major child, sir. And gene therapy, it is newly ongoing method in which lentivirus, which is a group of retrovirus, it is combined with the beta globin gene and is injected into the patient so that it is a genetic cure for the patient, sir.
Yeah, hydroxyurea actually helps by committing the erythrocytes into, erythrocyte progenitor cells, and initially there is a selection of HbFs in that. So that way you will find that people put on hydroxyurea have more HbF and hence decreased requirements. Okay, and genetic therapy is with respect to introducing gene editing tools are available. So they don't edit the beta globulin, but what they do is they edit the BCL11A, B cell lymphoma 11A, or KLF or EKLF. Okay, so these sites are the ones which suppress HbF. Okay, so the direct implication of putting beta chain into the cell, into the what you call
it's a vector.
Yeah, it is a lentiviral vector which is used to put beta globulin into the totipotential cell from the fetus and then trying to see whether it would help. It has not met with much success, but gene editing has helped a bit. Okay, these are still experimental as such. These are still experimental. Okay, prenatal diagnosis. And how important it is?
If the parents have not completed their family, it is very important, sir. We should ask that history, and then it is carried out from either chorionic villus sampling or amniocentesis, mostly from amniocentesis. Chorionic villus sampling is not done because of the 1 to 2% fetal loss and limb reduction defects. A sample is taken and fetal DNA is tested using PCR, and thalassemia major is diagnosed antenatally.
Patient is advised abortion if they are Thal major. If they have Thal intermedia, then they are given the option, and if the child is otherwise normal, then they go for that child. Fine. Thank you.
Thank you, sir.